Hi, I'm Lindsey Smith, welcoming you to Raise the Line with Elsevier, an ongoing exploration about how to improve health and healthcare. Today, we're close to the 6th anniversary of the COVID-19 lockdown, and we're speaking with one of the world's foremost microbiologists and global health experts, Sir Peter Piot, who has spent his long career at the forefront of efforts to combat deadly diseases. After helping discover the Ebola virus in 1976 and leading efforts to contain the first Ebola outbreak, Dr. Piot became a pioneering researcher into HIV and AIDS. He later served as the founding executive director of Joint United Nations Program on HIV and AIDS and as United Nations Under-Secretary General, where he transformed the global response to that disease. In addition to holding key positions at the UN and World Health Organization, Dr. Piot has had a busy academic career, teaching at several prestigious universities, authoring 16 books and over 600 scientific articles, and formerly serving as director of the London School of Hygiene and Tropical Medicine, where he is still a professor of global health. We'll be exploring his perspective on global health systems and their ability to respond to serious threats in what he calls an age of pandemics, among other related issues. Thanks so much for joining us today, Dr. Piot.
Nice to be with you, Lindsey.
So I'd like to start with you. Can you tell us what first drew you into medicine?
Well, I grew up in a small village, actually in a forest in Flanders, in Belgium, and there was not much to do, but I was always very interested in science. I'm very driven by curiosity. On the one hand, I read a lot, I had a microscope, and I was also interested in people. And next door, my village was a birth house, the only thing that was interesting in the area, and that was the birth house of Father Damien, who became a hero in terms of leprosy and died of leprosy himself. And so that's how I got really interested in. But I started actually first in engineering at the university. But then I wanted to do something that's useful for people, that's driven by science, by curiosity, and I needed a passport for the world because I wanted to get out of my small village.
That's amazing. I always think it's so interesting how those early experiences really shaped your whole path, and
Yes.
The fact that your interest in science and curiosity in people eventually turned into work with such a huge global impact in healthcare, I think is really inspiring. So let's go back to early in your career. You helped fight the first Ebola outbreak. Can you tell us how that experience shaped the way you think about outbreak response and what lessons stay with you today?
Yeah, when I think of it, this is exactly 50 years ago in a few months' time. So not only am I getting old, but it shows how far we've come. And the first lesson, in a sense, is that anything can happen. It's not that, when sometimes you discover a new virus because you're really actively looking for it and for the cause of something, like what causes cervical cancer and that they led to human papillomavirus. But in this case, it was just a sample that arrived from what was then called Zaire, now the Democratic Republic of Congo, and we isolated the virus, a new virus. And that was in Antwerp and Institute of Tropical Medicine, but it was at the US CDC in Atlanta that they could confirm was new. So I think the first lesson is really anything can happen. And think of COVID. I mean, it came out of the blue. I think of the largest epidemic of the last 100 years is HIV. It was also a new virus, and in this case, completely different from a respiratory virus that's like coronavirus, a sexually transmitted one. And what they have in common is their zoonosis. So in other words, they always come from some other animal than us human, Homo sapiens. And I think that the early career experience was one, I knew nothing when I came, and in today's world, I would not be qualified and be allowed to go investigate an epidemic. I'd never been to Africa. I had never investigated an epidemic. I was 27, still in training, in residence, infectious diseases and clinical microbiology. But I learned a lot from my, colleagues, Professor Muyembe particularly, who was the first one to see a patient, and from folks from CDC, from Centers for Disease Control, particularly Joel Bremen. And what I saw from the beginning is that the most important thing is that you need to listen to people. Because when you are dealing with an epidemic of unknown origin, the number one question is, besides knowing what the virus is or the cause is how is this transmitted? Is this mosquitoes, water, sex, airborne, etc.? Not only to stop the epidemic, because that's key, but also for your own protection, because I was particularly worried that would be mosquito-borne, transmitted. So it's just by talking to people, listening, not only filling in questionnaires, but also to do some very simple things and reminding the younger folks among the audience that this was a time there was no mobile phone. I'm not even talking about AI and nothing digital. Doesn't exist. We had to do it all by hand. And so you define the epidemic in terms of time, place, and person. How does it evolve? Are we at the top of the epidemic? Is it already going down? Place? Where are the people who, in this case of Ebola, our case definition was someone who died, and the case fatality rate was over 90%. So that made it so-called easier to define a case. And that came actually from the first well-documented cholera epidemic in London, where John Snow saw that it's the people who drew water from a particular water pump who all got cholera. And he did that by mapping. So we mapped and we found it's people who were close to the hospital, etc. And then most importantly, who are the people? And you divide them by age and sex. Very simple things, men, women, by age. And then we saw that, one, there were hardly any children, which was immediately we thought, okay, you can nearly exclude mosquitoes because why would they only bite adults? And two, we saw that there was a peak in young adults and there were about double as many women as men between, 16 and 25, something like that. So then you think, okay, what's the difference? You learn from differences. And we were a bunch of men, so it took us a day to understand that the difference between men and women at that age, women can get pregnant and so on. Then you start with a hypothesis. And indeed, the excess in women were women who had been just delivered or who were pregnant. And then you said, oh, but is this biological? Does pregnancy make you more vulnerable to a virus? Or is it something else? And then we thought, okay, let's see where they had been. And they all had visited the antenatal consultation at the hospital where that was the epicenter. Anyway, so to make a long story short, that's why we identified that it was two things that were critical. It's close contact, household contacts. 11 of 17 nurses had died in that hospital from Ebola. So caring for someone, so very close contact to body fluids. And secondly, injections, because they were contaminated injections. They were using the same syringes, 3 syringes to give an injection to everybody. I'm telling that because it's not always very complicated. So the lessons are really, listen, be very fast. You can't do the sophisticated investigated before you take decisions on what measures to take, because, in epidemics is the earlier you can act, the more cases, deaths, and so you can prevent, because by definition, you get it from someone else. So if you prevent someone to become infected, that means that you prevent maybe 100 people, maybe only one, but many others to be infected. That's why, the title of my memoir is No Time to Lose. And that means that, when you're an academic, you say usually, oh, we need more research, we need to understand. And that is, of course, true from a science perspective, but in terms of policy and action, you need to take decisions. And sometimes on this lack of facts, of evidence, and you need to take risks. And, I was interviewed in 2020 in February by the Financial Times. And the first question the journalist asked, you're exaggerating now with all this pandemic and so on. I said, well, I'd rather be accused of exaggerating than not doing my job. And that became the title of there was a full-page article. And even then, I must admit, I underestimated what COVID would be. But then it was thought to exaggerate. So it is really, you have to act fast, but you have to organize and you have to make sure that every day you know a bit more. You have better evidence. So you act, but you make it clear that the knowledge base is increased.
Thank you for walking us through your way of thinking. That was fascinating. And it sounded like as you were speaking that so many of those lessons are still really relevant today.
Yeah, I think so. Although now we have AI, you can ask Claude or whatever,
So you had mentioned both HIV and AIDS and COVID-19. So let's start with HIV and AIDS. So through your work at Joint United Nations Program on HIV and AIDS, you played a major role in really mobilizing global funding and expanding access to HIV treatment. Can you take us through the key steps that made that possible?
Yeah, first of all, I never thought I would want to be a UN bureaucrat, and then work in the UN system or whatever. But our team had been working on HIV in Congo and in Kenya, and we were the ones who showed that this is also a heterosexual problem, not only for gay men, as that was the dogma in these days. And it was really, every 5-6 months we had something new and how it's transmitted and the origin, and we found the virus in chimpanzees and how to prevent it. But I got very frustrated because every year more people would die. And so I said, how long can I study this unfolding disaster? I want to stop it. I want to do something. And that's how I ended up in the World Health Organization and then UNAIDS. I wanted to be more in policy and that I can do something the larger scale. And that was in 1995. And we were, in a sense, lucky that in 96, that an effective treatment for HIV infection was announced. Actually in Vancouver, Canada, at the International AIDS Society Conference. And that changed everything because until then, AIDS was a death sentence. And all my patients, and many, all died. And it was very tough also. In these days, they were my age. And that was both in Belgium and in Africa. So the treatment came on, and I spoke in the opening session of that conference where this was announced, and I said, this is fantastic news, but we should not rest until everybody has access to it, everybody who needs it, because the cost of that was then about $14,000 per person per year. And in today's dollars is probably 3 times as much. And so that became, something between a passion and an obsession. I said, we need to make sure that treatment, life-saving, is accessible for everybody, particularly since by then in the 90s and certainly even worse later, that the overwhelming majority of people living with HIV were in sub-Saharan Africa and also in the Caribbean in terms of prevalence. Of course, we had lots of populations affected also in North America and Europe, no doubt. So I created UNAIDS. It was a new initiative in the UN system to lead and coordinate all the efforts around HIV. And why a special program? Because it had become a real, what let's call it, development problem. And so it killed educated people, and certainly in the worst affected countries, millions of orphans, just name it. It was not just anymore a health problem, very bad one, but it affected entire societies, even security, even armed forces, just name it. And after a few years' time, I felt we were a complete failure. I can sometimes be hard on myself, but I said, I have only one criteria. Will there fewer people die or not? That's success. And the number of cases went up and up and up and continued until actually 2003 or 4. So what did I do? I brought together a number of people. Some were my friends and some were big critics, and put the problem on the table. It's a bit of a high-risk strategy. You say, look, we're a failure. We're not doing something what is needed. Treatment was still not available. In terms of prevention, condoms was about it, and abstinence and so on, and fidelity. That was so I called them, and in these days, in diplomatic terms, it's called a non-meeting. In other words, there are no records. Today would be impossible but this was in 97, or 8, yes. There were no social media. You couldn't tweet and so on. So that was, it remained discreet. And what was the conclusion? It was pretty tough for me in the beginning, but that we need to redefine HIV in different way, not just as a medical problem, but at the end of the day, there are only 2 things that really matter in big politics and so on, and that's the economy and its security. And so let's define and redefine HIV. What does it do to the economy? And that we had already started working on it. and also in terms of security. Okay, and then I have a simple mind, and then I say, okay, where do we go? Security, you need to talk to the armed forces with the UN Security Council, etc. For economy, go to Davos, the World Economic Forum, you go to talk to ministers of finance. So I neglected a bit the ministers of health and the health community and tried to bring that message elsewhere. And in the end, it started working and put it on the political agenda also. Again, I wasn't born with that kind of, approach or attitude, but I was so desperate to make sure that it gets on top agenda, because without being on the political agenda, there's no money, and policy decisions that can be very controversial, because there was a lot of denial, because it's about sex and drugs and so on. That was not so very popular and still isn't. So that we could really elevate it to the at the political level. And I thought also that we have to make sure that at some point the stars have to be aligned. And these stars are political commitment, there is money, and that we know what works. We need to identify also. You can say this is a very bad problem, and then you convince the president or prime minister of a country and they say, fine, you convince me, what do I do? And if you can't come up with something doable, concrete, then they say, okay, come back when you have a solution. Not that there was a solution, but this treatment was a really important one. And so that also brought us then to negotiate with Big Pharma. There were no generic versions, of the drugs. To square a circle, that's not so easy. On the one hand, we needed lower prices. On the other hand, we didn't want to kill innovation, because these initial drugs were great, they were saving lives, but they were not really what we need today. We know that. I know you needed to take, can't remember, but it's like between 15 and 20 pills a day. Today, it's 1 pill a day. So that means that we needed to work with industry, but there were also the activists, and we needed to find the money. And all that came together around the millennium. There was a special session of the United Nations General Assembly. Why is that important? Because there were over 45 heads of state coming and say, yes, we have a problem. Also, we did in Africa, in the Caribbean. And turning points, there were two, I would say. Was Kofi Annan, who was my boss, the Secretary General of the United Nations, when he called for a war chest that led to the creation of the Global Fund to fight AIDS, TB, malaria. So it was the compromise, to say so, was that to add tuberculosis and malaria, which I totally agree with. And that started in 2003. And then President Bush, who in 2003 called for the creation of what's now PEPFAR, the President's Emergency Plan for AIDS Relief. And until then, I'd been fighting. I was happy when there was 100 million more, this and that. But I always knew that we need to move from the M word to the B word, as I once said in a speech, from millions to billions, an issue that is so huge. And all that happened around the millennium, 2000, 2001, 2002. And that, I think, has really led to millions of lives saved. But you needed all these elements. As I said, the stars have to be aligned. If you don't have the leadership, you can't address these delicate and sensitive issues. There won't be money. If the price of drugs would have still be the same, would have not been possible. At the same time, Indian generic manufacturers started to produce it, but in full respect of intellectual property also. So it was a lot of things that when I went to medical school, I could not have dreamt that I would have been involved in. Was more diplomacy, activism, negotiations, just name it.
That sounded like a really challenging time early on until you guys shifted and kind of got that life-saving treatment.
Yeah, I didn't sleep much, I tell you. Yeah.
And then trying to make it accessible.
Yeah.
You said you define success as less deaths for HIV and AIDS, and then eventually a breakthrough was made, which sounds like a blend of science, diplomacy, and serious advocacy work.
Yes.
So you've described our era as the age of pandemics. Can you tell us what's behind that view, and what does it mean for global health moving forward?
Yeah, it's actually was inspired by two things. One, that COVID, of course, that's when you think of it, we still are living with the consequences, even political consequences, even consequences that turned away people from vaccines, for example. It led to a decline in trust in public health, in authorities and so on. But it killed, let's not forget, well over 20 million people. That's not a detail. That's one thing. And then on the other hand, what we see is an increase in the frequency of epidemics. Not necessarily of a pandemic, but let's not forget, you can have outbreaks in your own state or city or in a whole region. And some viruses only circulate, let's say, in Africa, like Lassa, and others in Asia and some. And also because of population pressure, deforestation, some climate change, there are more viruses that are jumping from animals where they're living happily with their host, and they're infecting us humans. And in most cases, fortunately, that leads to nothing. I mean, it doesn't take the virus. We're not adapted for the virus. We don't have the receptors, whatever. And in some it does, but it's limited to a few people. But we see an increase of that happening. And so that's why I'm convinced that there will be more and more of these epidemics, and hopefully very few will develop a pandemic. And we can't really prevent what's called spillover from an animal. It can be a bird, can be a stupid chicken or a nice chicken, or it can be a pig, it can be whatever, chimpanzees and so on, squirrels, bats and so on. But what we can prevent is that it develops into a huge epidemic and pandemic, and that's pandemic preparedness. So it's, maybe I should have said an area of epidemics rather than pandemics, but also because we're far more mobile. In the old days, over 100 years ago, was the Spanish flu. The fastest transport was trains in some places, but there were not that many. And yet it killed about 50 million people. So it spread. And in today's world, we've seen examples, you are infected, you're in a place in one part of the world, and you take the plane, and the next day you're somewhere else, and you can infect I don't know how many people. So we're far more vulnerable as a world for rapid spread of viruses in general.
That framing is really clear, and I know underscores that we still have a lot more work to do in this planning for pandemics in the future. So if you had a magic wand, what changes would you make right now to improve public health globally?
Yeah, I think that we are in a much better space in terms of technology, developing new vaccines, drugs, although we have always the problem of potentially of antimicrobial resistance. But I think that the one thing that probably I'm the most concerned about is lack of trust, the declining trust, and misinformation and disinformation. It's always difficult to say the one thing because there is no such thing, but still, that is something that I had underestimated and that I think was not such a determined or impact of public health. And the second point I would say is that expenses in healthcare is going up and up and up. And that's okay because we're getting older and so on. And also the interventions getting more sophisticated and more expensive. But we should also invest far more in prevention, in keeping people healthy, not in dealing only with people with their diseases. And I think that the good news is that we all live longer on the average. It's amazing how life expectancy has gone up. In most cases, it's gone down for a while, but with COVID. But in general, the problem is that we've been adding years to our life, but not life to our years, because at the end, there is a difference between biological age, chronological age, and healthy lifespan, as it's called. And that's mostly chronic conditions from diabetes, obesity, cardiovascular diseases, and so on. And many of that are preventable. I mean, be it from smoking, exercise, and all the things we know. This is not rocket science. We have had some drugs now, anti-GLP-1, and so that's also, but the expenditure and the efforts on prevention is, absolutely minimal and insufficient. And yet that could save us a lot of money and bring far better quality of life. So these are for me the two things, we need to deal with distrust, and it's not just a matter of information, because mistrust can be about something completely different. Sometimes it is motivated, it's generated. We should not be naive, be it political, even by a foreign nation. But also we need to invest more in prevention, and where some innovation can help. And I think that with the current AI can make things much worse, but it also can be used to, generate positive attitudes. And in public health, we're neglecting that, or when we introduce a new intervention also, we neglect to listen to people and what is it. And that's why communication is so crucial. But understanding also what's behind it. And we scientists, we think often, okay, people don't understand, we should explain more. I've learned one thing with COVID. That helps some people, that's what they're asking for, but it's about other things. And I don't always understand it, to be honest.
Absolutely. Decline in trust and misinformation has been a huge topic for us on the podcast as well. And we've also heard a lot about health prevention. Before we wrap up today's episode, I'd like to get your advice for our listeners tuning into the podcast today. So we have many students and early career professionals listening in. What advice would you give them as they face today's challenges and build their careers in healthcare?
Well, I assume that whoever goes into medical or health-related training is passionate about health and wants to help people also and save lives. I give often commencement addresses and all, and I always advise it, one, do what you're passionate about, what you're really interested about, and not necessarily what you think the market will need. Because the market changes, and look at all the people who are into computing and coding and all that, and with AI, they're losing their jobs, and that's very sad. So do what you're passionate about, and secondly, make sure that you are very good, that you dig in your heels into something that you're very good at, that you can help. You need to be technically, really top. We owe that to people, because let's not forget how privileged we are, and also privileged to save lives. And then what are the biggest challenges often is the bureaucracy, all the regulations and so on. Some make good sense, and others I wonder sometimes. So let's not get bogged down by that. And then finally, I see in some countries that the medical thinking and training is too much like, algorithms, in the sense that it's binary. Like I've seen it in the UK, you have to follow the binary algorithms, and then you go for this to that, and you look at one organ and so on. No, it's about people. Look at a patient, a person as a whole, listen, touch. Don't just stay at your screen and try to see what the next step is. And because I think that it's not only will give you more satisfaction and have more contact with the patient, which then will provide you with more information that's useful, but also certainly when people get older, but even before, it's very often so that when you see a patient that there are multiple issues at the same time. And that includes also mental health that we should not neglect. So it's about people as patients, and not about a heart or a kidney or, the nose or whatever, the eyes. That's all for me. I think that's important.
That's a really valuable perspective, and I liked what you said there about really personalizing that approach to that individual and that patient. That is a great way to wrap up today's episode. Thank you so much for being with us today, and thank you for all of your incredible work.
Thank you, Lindsey.
Thanks again to Dr. Piot for joining us and helping put today's global health challenges into perspective. Dr. Piot is one of the most influential figures in modern global health, known for helping discover the Ebola virus and shaping the world's response to HIV and AIDS. His decades of scientific leadership, diplomacy, and advocacy have fundamentally changed how we understand and confront infectious diseases today. I'm Lindsey Smith. Thanks for checking out today's show. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.